or for some of us, we may even have our own internal traumas that we have to deal with as well. So to do this training, I have brought in my opinion, the two best people to do this training. They have almost like a personal mission to turn Tucson into a trauma-informed city, a trauma care city, which I am 100% on board with them, and this is why I wanted to bring everybody in, as many people as we can, everybody from Higher Ground. We're recording this, that way everybody who gets, everybody who works or volunteers at Higher Ground can also take advantage of this training. And I'll introduce them. First one is Dr. Beverly Tobiasen. She is the clinical director for Pima County Juvenile Court Center, one of our partners, the Evening Reporting Center here. She received her doctorate in psychology from the University of St. Thomas and her master's degrees in community counseling and rehabilitation counseling from St. Cloud State University. She has almost 30 years of community mental health experience, providing individual, group, and family psychotherapy, assessment, program development, clinical supervision, and consultation for children, youth, and families in outpatient, inpatient, day treatment, and in-home settings. Woo! She is currently responsible for assuring court-involved youth are receiving research-based mental health treatment services and assists in evaluating the effectiveness of those services. She also provides oversight for the Trauma Responsive Practices Initiative at the court. Second trainer, Ms. Chris Swenson-Smith, MSW, is a consultant for the Substance Abuse and Mental Health Services Administration, National Drug Court Institute, and Pima County Juvenile Court. She's recently retired Children and Family Services Division Director at Pima County Juvenile Court in Tucson, Arizona, and previously worked at Child Protective Services as an ongoing unit supervisor, investigator, and ongoing case manager at Pima County Juvenile Court as a juvenile probation officer, and at Arizona Children's Home as an adoption social worker. She has been the project director for 5 SAMHSA grants, one of which first introduced trauma-focused treatment to family drug court. She has completed the ACE Train the Trainer and has presented at the National Association of Drug Court Professionals and National Association of Juvenile and Family Court Judges and National CASA annual conferences, the Illinois Supreme Court, Georgia Family Drug Courts, and the Arizona Problem Solving Courts Conference on topics ranging from trauma to evidence-based practices to data-driven dependency.
That makes me tired.
And let me just put it this way. Ms. Swenson-Smith here thinks this work matters so much that even though she has retired, she comes out just to do this training with Dr. Tobiasen. That's how dedicated and passionate they are, just as we are passionate about developing our youth and seeing past a lot of these things that are happening to them. They are just as passionate in making sure that the people providing the services for our youth understand these concepts. So, you know, in speaking with Dr. Tobiasen over the phone, I mean, we could have gone hours just sharing and brainstorming. So I'm really excited for this. So without further ado,
Now?
yeah.
My apologies for using the microphone. I woke up with the starts of a cold today, so I'm hoping my voice stays with me. We've talked a lot about trauma-informed care. Pima County Juvenile Court is considered one of the leaders in being a trauma, we refer to it as responsive court. We didn't like the passivity of the language of just being informed. We wanted to respond to the trauma. And everything I've heard about your school, you are also doing the same thing. You are responding. You are not just informing yourselves. We have several hours worth of material, and we're going to blast through it pretty quick. Some of this may be redundant with what you've had thus far, but bear with us. And if we're taking too much time in an area you know a lot about, ask us to move on and we will move on. The afternoon we are going to be talking about vicarious or secondary trauma. And again, that is how you as helpers are traumatized by the work you do. All of us are. So with no further ado, we always like to start our training with a slide that talks about hope and resiliency. So Helen Keller, we love this quote, "All the world is full of suffering, it is also full of overcoming." Many of us that work in the helping fields and with children that come from traumatic backgrounds have our own histories of trauma. It is what drives us to do this work. You know, it's just been a week for me of technological difficulties. We are assuming you know the kids you work with. They come to you with a vast array of traumas, often multiple traumas, and sometimes you know that there's probably trauma, but you don't even know what it is. We'd like to start with types of trauma, and I'll go through this pretty quickly because I suspect you've all had it. First is an acute trauma. That is a one-episode traumatic event. That's a car accident. It's a rape. It is a witnessing of violence. So it is just one incident of trauma. We also have chronic trauma that is repeated. So the trauma is long-standing, often from abuse, neglect, a contentious divorce. We're also going to be talking quite a bit about complex trauma. Complex trauma is chronic trauma in multiple domains of our lives, but also as perpetrated by our caregivers, those that are supposed to be protecting us. Now, trauma prevalence. And keep in mind that with the first piece of research, that approximately 25% of all children, by the time they reach age 16, will have experienced at least one traumatic event. So one acute traumatic event. We can see the different types of trauma in the next bullet. One of the reasons Chris and I do this work is that 100%, can I repeat that, 100% of children in child welfare. I'm going to repeat it one more time. 100% of our child welfare, our DCS kids, have a history of substantiated abuse, neglect, or abandonment. And what surprises a lot of people is upwards to 93% of children in the juvenile justice system have a history of trauma. There was some additional research on juvenile justice involved children where they asked how many incidents of trauma had you experienced before you got into the juvenile justice system. The average number were 15 incidents of trauma. So the kids that come through our system, and you know these kids, you work with these kids, you're nurturing these kids, extreme trauma histories.
Can I have a show of hands of those of you who have heard of the ACE study, Adverse Childhood Experience? About a dozen of you. Good. Okay. One of the most fascinating studies I've ever heard about. It changed everything for me when I first heard about it, and I heard about it from one of the researchers, Dr. Vincent Filletti, who, with Dr. Robert Anda, started this study. And I realized it was really the basis of all of my work, and I didn't know it. And it changed how I approached everything. In other words for childhood experience or toxic stress or childhood trauma, those terms are used interchangeably. It'll go slow. So here's a new, I borrowed this from somebody else's presentation, actually in Washington State, where they're doing amazing work around starting with their schools, becoming trauma-responsive communities. So again, ACEs are adverse childhood experiences. They're They're in three, you can see on your handouts there, three separate types of ACEs. There's abuse, so something like physical abuse or sexual abuse. There's neglect, physical neglect, emotional neglect, and then household dysfunction, which are things like parents having substance abuse problems, divorced parents, parents being incarcerated, domestic violence, violence. So let me tell you a little bit more. We'll talk about these stats, but let me tell you a little bit more about the ACE study. Over 17,000 subjects in this study, and they're still following the ones who are still living. It started at, they were doing some research at Kaiser Permanente Hospital in San Diego, and in cooperation with the Centers for Disease Control, they were looking at why folks with obesity who had gone through medical weight loss gained back the weight. And so that's what they started looking at. They had no idea they were going to stumble onto this, which was when they began to do not just looking at physical characteristics or medical problems. Is this still working? It sounds like it's going in now. They started having social workers interview the subjects to see, if there was anything that happened in their lifetime that might have affected them, and they stumbled onto all kinds of things. One of the subjects admitted that she had been sexually abused by an uncle chronically for most of her childhood, had never told anybody until she told that researcher. She had a twin sister in the study, so they asked her the question, did this happen to you too? It did. So as they were going through and subjects were identifying different things that happened to them, experiences in their childhood, they were just writing them all down, and eventually they were able to correlate as they followed these subjects, not just looking at obesity, all kinds of physical, emotional, social, economic problems they were experiencing in their life, and they were able to correlate the number of adverse childhood experiences with the likelihood that they would experience some of these problems as adults across the board. So it's scored this way. So what they revealed from these 17,000 people were about 28% of them had experienced physical abuse. 20 had, sorry, is it on? You matched 20% sexual abuse and 10% emotional, 14 neglect, almost 10% physical neglect, the rest was emotional, and then a ton of household dysfunction. Lots of parental substance abuse, 30% almost of the people in the study had had a parent who struggled with alcohol or drug abuse. Divorce was prevalent, mental illness in the home, mother treated violently. They separated this out. When you're talking about domestic violence, it can be any intimate partner violence, right? Male on female, female on male, female on female, male on male. In this case, it was just the one that came up over and over again that they found correlated, and that was the mother being treated violently. Actually, even the stepmother, the child was being raised with a stepmother. And about 5% of the subjects had a parent who had been incarcerated. So of all of those 17,000 subjects, 26% had only one ACE, 36% had none. So more than a third had no adverse childhood experience at all. 64% had at least one, 16% had two, 9% had three, and 12% had four or more. And they kind of put that into one category. It goes up to a 10. Because pretty much everything 4 to 10 is a kind of a tipping point where you really see some of those adult problems develop. So these were middle class people, mostly middle-aged, with health insurance. So we're not talking about any kind of special population. Ethnically divided just like the population of the United States. So really, those 17,000 people, as they're still being followed, aren't really the subject of this anymore. Who's the subject of this study now? Everybody. They represent our population, And so the estimates of how many people in our population have those number of ACE scores can be correlated with the actual general population. So we just look at them as us. That's us we're following right now. So they got it down to those 10 different things that we talked about here. These 10 different things and adverse experiences happened to them. The higher the score, the higher the risk of having lots of problems later, starting with behavioral problems, mental health, substance abuse and domestic violence themselves, mental illness, being incarcerated, having low income, having job problems, what did we miss? Suicide attempts, of course, depression. They're starting to now correlate it with some physical illnesses as the subjects have gotten older and older and have begun to pass away. It's now linked with heart disease, severe obesity, diabetes, and cancer, even strokes. So we're talking about a public health issue is what it comes down to. Go to the next one. In your packet, you have the ACE questionnaire. There's 10 questions on it. It says finding your ACE score at the top. It's really quite simple, actually. You can't get more than 1 point for any of these. Your score on each question is either a 0 or a 1. And then you add them up at the bottom, and that's your ACE score. It doesn't matter how many times it happened. So if they're asking about whether there was physical abuse of a person as a child, it doesn't matter whether it was once or 100 times. That's a score of 1 if it happened at all. And that's based on what they found in here. They're not saying that if a child is chronically traumatized by physical abuse, it isn't going to be worse than a child just hit one time. But they say often or very often in here. So that score is the ACE score. And the higher the ACE score, the more likely that a child will grow up to have many of the problems we just talked about. So as you're looking at those questions, does anything come up for you that you're wondering about? You see anything that's left off? Did you live with anyone who was a problem drinker, alcoholic, or who used street drugs? It's yours. It's if you felt like it was. If you were a child and you thought that was a problem, then it was. Whether they were diagnosed, and a lot of people are never diagnosed with alcoholism, they go through their whole life without getting it to recover, or not being diagnosed either. Do you see anything missing? Yeah, I thought so too. It's not on there. Death of a parent. They were using that question at one point, but it seemed like the parent being incarcerated or the parents being divorced were more likely to be correlated with problems later. But certainly, a child experiencing the death of a loved one, especially a parent, has to be traumatic. What always stands out to me is school violence. Like, what about kids who experienced a school shooting and survived, but saw that happen? How could that not be traumatic and affect them their whole life? But the reason it's not on here is because the subjects were in school so long ago, those things weren't happening then, so that never ever came up. But if they went through a whole new cohort, like starting with our kids right now, that would have to be a question, I would think. What else? Anything else on there stand out to you? Probably because she mentioned car accidents and hospitalizations, like the hospitalization of a child. Yes, those would be traumatic. They'd be acute trauma. And those do happen to quite a few people. I mean, who has not been in a car accident? Maybe not as a child, but weren't necessarily correlated here because they weren't as chronic, but they didn't come up as something with these subjects, especially the ones that. So people might have mentioned them, but they weren't the people who had the lifelong problems that were identified. So if you want to do your own ACE score, go ahead and do it. Everyone does. Don't panic. We work with tons of people with ACE scores of 6, 7, and 8. I wasn't going to name any names. So high ACE scores, yes, they are correlated with some lifetime problems. Does it mean you are doomed to have those lifetime problems? No. And so much more is being done on resilience now and how you balance out that childhood trauma, and we're going to talk more about that later. So the very first study that Dr. Anda and Dr. Felitti published was called Turning Gold into Lead. And really, these photos just illustrate that. You start with an infant who has all the potential in the world, add in a whole bunch of adverse childhood experience, you end up with someone with some problems pretty quickly into their adulthood. This guy looks like he's already been arrested, might be dealing with some mental illness, substance abuse, other things. And you end up with someone who ages early and doesn't age well, if they age at all. Interestingly, when that paper was first published, and remember, it was from a respected physician from a major hospital in California and the Centers for Disease Control, and no one wanted to hear about it here. The medical community in the United States, they were being given, they were being asked to present in Europe far more than they were being asked to present here. That's changed. It's finally made it out. So much so that Dr. Richard Block, who used to be the president of the American Academy of Pediatrics, said that the children's exposure to ACEs is the greatest unaddressed public health threat of our time. So it's a public health threat. What else is a public health threat? Yes, they're talking about the opioid crisis as a public health threat. I totally agree, but it's just a part of this, isn't it? Really. What else? What's a public health threat? Flu, or flu season. Have you heard so much about flu shots and flu epidemic? Diabetes, yeah. There's a lot of publicity about that, a lot of information, a lot of helping materials, a lot of attention. How often do you hear about this? That's a public health threat. And if you think of all the things that happen to kids who grow up, who have these experiences, that's going to affect everyone. If they are experiencing mental health problems, drug abuse, incarceration, violence, how does that affect all of us? Go ahead. Oh, we talked about this. They started out with 26,000, they ended up with just over 17,000. Average age was 57. They're gonna keep going, they're still following. The CDC is carrying the data right now. There's, in the very end of your PowerPoint, and we'll have it up here, are the websites, and acestudy.org gives you the overall explanation of the study. But Centers for Disease Control is holding all the research, and it's continuing. There's papers being published all the time. There was just another one that came out last year. There it is. Just a little bit of stats for kids in Arizona. The national average of having 2 or more ACEs is 22.6. Average 2 or more in Arizona is 31, or the total in Arizona is 31%. About 42% of our kids have 0. That's great. But it's kids 0 to 17, so some of them aren't done with their childhood. 26% have 1 ACE. So I don't have stats on anything. We're not great in Arizona about collecting this. Other states are doing a great job. So just remember this, about 1/3 of adults, so maybe 1/3 of you, have an ACE score of 0. Anyone willing to share that you have an ACE score of 0? Wow. Okay, we got one. We should, if we were matching this study, have about 10%. So that tells us a lot about folks who are in this room. And why do you work helping people? It seems like people with high ACE scores are overrepresented in the helping professions. And that's a good thing. I think it's a good thing. So this just gives you an illustration of how the increasing number of adverse childhood experiences really tips exponentially your risk of having a lot of adult lifetime problems. So let's just take one example. If you have an ACE score of 0 back there, you have a 1 in 69 chance of becoming an alcoholic. If you have an ACE score of 3, you have a 1 in 9. That was quite a jump. That was only 3 lifetime or adverse experiences. If you have an ACE score of 7 or above, you have a 1 in 6. This one is crazy. 1 in 480 of people who have an ACE score of 0 use IV drugs. 1 in 43 with an ACE score of 3 uses IV drugs. 1 in 30 for 7 and above. And then the suicide attempts, even worse. 1 in 96 of people with an ACE score of 0 will attempt suicide. 1 in 10 of with an ACE score of 3. 1 in 5 with an ACE score of 7 or up. So you can see there's kind of tipping points right when you get past this 3. So we talked about that. It's a number of different categories, not the chronicity of each one happening that determine your ACE score. But they do have a cumulative effect, and they do have an interrelated effect. For example, if the mother is treated violently and there's alcohol abuse in the home, you see that it goes up double. So adding to any of these childhood experiences, mother treated violently, mental illness, drug use, suicide attempt, or member in prison, and a parent abusing alcohol, the scores go up. If there's 2 or more parents, you can see it's even higher. So when you put those 2 things together, they seem to be related. Now that makes sense to you. Think about some of your kids, right? So if they've seen domestic violence in their home and they've got an alcoholic parent, that they seem to reach a different level than some of the other kids. Also, those 2 things might be highly related. So there's still studies like this going on. Dr. Tobias and I have really become interested in this, and having worked mostly with child welfare, where we're working with both the child and the parent, the family as a unit, we have to think about the whole family. So when kids are removed by Department of Child Safety, our judges are supposed to make orders and placements for them for their best interest. But they have to do that in the context of the family. The goal of any child welfare case in court is to reunify the family. And science, research says that's what works best for kids. Some kids can never go home and they're adopted, and some of them do great. But the law says, and it's based on research, that you have to try to reunify that family in almost every case, unless it's the most severe abuse or a child was murdered or something like that. But in every case, you have to start with trying to reunify the family. So if that's true, do you just want to work on getting the parents in a good place? Or do you just want to work on getting the kids in a good place? Or do you want to work on the whole family? And it's pretty clear that you need to work on the whole family, because traumatized children become traumatized parents. So this is where my eyes got opened. I was listening to Dr. Felivi talk about this. At the time I was running the family drug court, and these were parents in child welfare cases whose kids had been removed because of their drug abuse or alcohol abuse. And we were doing a drug court just like criminal drug courts, where the parents had to come every week to see a judge. They'd be held accountable every week. They did more drug screens. We were total emphasis on treatment, making sure they could get the best possible treatment. They had lots of support. We weren't punitive. We were even contracting out for treatment that we thought was the best in Tucson. And still, almost half of our parents couldn't make it through family drug court with all that support, even seeing the judge every week, having a special case manager assigned just to them with very low caseloads. I mean, it was a dream approach, and still this was happening. And then I saw Dr. Felitti speaking and talking about this ACE, and it hit me. We weren't getting to the real problem of these parents. No one was asking them, what happened to you? We were just putting them into drug treatment. Now, today, I'm happy to report that many drug and alcohol treatment agencies get to that. They consider it part of the drug and alcohol treatment. Have you known people who have been addicted to serious drugs? Probably. Do you think that was their dream? Did they set out to do that? To have a life like that? Who wants a life like that? What happened? What turned the gold into lead? So now we've got these parents who were traumatized children, and in the case of our clients in our family drug court, it had never been addressed. Most of the time they hadn't told anyone. We surveyed our own parents and said, did any of these things happen to you within the ACE study? And 97% said yes. Guess which one was the highest? We had almost all women in the court. What was the highest of all those things that could have happened to them as a child? What?
Sexually harassed one.
They were sexually abused. Yep. That was almost the majority of them. Never had told anybody in some cases, and definitely had never had treatment. One out of all the clients had ever had any treatment for it. And now they've had children. And guess what? They've lost their own children. So now the children are traumatized because they've been exposed to their parents' substance abuse, and now removal from that parent. And whatever else was happening, domestic violence, anything else, if a parent became incarcerated. So traumatized children have traumatized parents who become traumatized, who have traumatized children. And that is why we're on this mission. We got to stop this cycle somehow. There's lots more. I've just changed the slide because the more recent studies have added a whole bunch more problems that come up for adults who have high ACE scores. Including, I mentioned the heart disease. Liver disease, there's now evidence that liver disease can be tied to financial stress, poor work performance, multiple sex partners, sexually transmitted diseases, unintended pregnancies, early initiation of sexual activity, adolescent pregnancy. Are you recognizing some of the kids you work with? And of course, I highlighted this one, poor academic achievement. It's huge. So that's what we do this presentation for a lot of schools. We've trained every elementary, middle school, and high school counselor in TUSD, the biggest district. We've been to Marana and Sunnyside and lots of charters because of this. ACEs are the greatest single predictor for health, attendance, and behavior. The second strongest predictor after special education status for academic failure. So is this important for you to know? Some of you are you here ones who are working specifically around kids who don't attend, truant kids? There you go. The relationship between academic achievement and health status appears much less related to income than to ACEs. So we know, and those who've worked in education field a long time, know that there is research that shows poverty is correlated with poor educational outcomes. ACEs are more likely to be what's really correlated with poor educational outcomes. Okay, there's a brain, that means it's Dr. Tobias.
Chris never does that. Chris, can you guys hear me? Yeah. Oh, good. I can't hear myself. So why is it important if children are experiencing distress instead of adults? Everybody in this room has experienced stress probably this week. But what is it about children? Well, children are predisposed to not be able to handle stress. It has to be moderated by those around them, by caregivers. They need safe, stable, nurturing relationships. That is how children learn to regulate their emotions. They cannot be left on their own to learn how to do this. Again, If a child, again, none of us, or very few of us, with one exception, get through life without very stressful things happening. But many of us are able to pull through it and to be resilient. And we're able to do that because of the caretakers, because of the helpers around us. And everybody in this room is one of those helpers. For the brain nerds, I love this particular slide. On this side is a healthy brain. This is a child's brain that has got his or her needs met. The one on the other side is the abused brain. And what we know is that the orange or red and yellow is activity in that brain. So it's the brain that's working as it's supposed to, where the black and purple are kind of nothing is happening. The two circles are, let me see, what is that? The temporal lobe, where we regulate emotions. And you can see in a healthy brain, there's activity going on in the temporal lobes. So that brain is able, they're starting to learn, they're able to regulate emotions. If you look at the abused brain, you'll see that there's not much going on there. This is a brain that is not able to regulate emotions. So our children, it is not that they are unwilling to regulate their emotions, they are unable. Now, what frightens me a little bit about the abused brain, where the most activity is going on, is at the brainstem. That's that primitive place. That is that fight, flight, freeze. That is that react. So there isn't a lot of cognition happening in the abused brain. Again, I think this slide just talks about the interrelationships within our body, the different systems, and how each of these systems affects another system, which is why the ACE study really determines that there are going to be significant behavioral and health, and even some people with significantly high numbers of ACEs die earlier. They die earlier, up to 20 years. So we've got our immune system, mine that's not working very well at this moment. The neuroendocrine system and the central nervous system, they are all interconnected. They will all connect and interfere with one another. So often we look at, some of the secondary behaviors, secondary to a high ACE score. And we used to blame them. Maybe you would be alcoholic if you had willpower, if you would just stop. But what we have learned through the ACE study is that problems are often personal solutions. These are solutions, these are adaptive solutions to the trauma. And trust me, any child who has been significantly traumatized, the first time they try drugs or alcohol, they're going to think they found nirvana. And they will have found nirvana on the short term, but it will develop later into a public health issue. And again, I think we just need to stop looking at bad habits, bad choices. These are survival techniques. These are adaptive coping mechanisms to the trauma. We also know through our research that ACEs are primary to the pipeline to prison. Absolutely primary. I think I talked earlier, upwards to 93% of juvenile justice involved children have significant trauma histories. But you can also see that even in the adult system, extremely high levels of trauma. It is the pipeline to prison. We also see strong correlations with serious job problems. As educators, isn't it your job to get children ready to join the workforce at some point? The ACEs, high ACEs, will interfere with successful job problems. Now, some of the age-specific signs and symptoms of trauma, and these are going to be more acute trauma. So the one-time incidences, the hospitalization, the car accident. So you can see in elementary age children, lots of distress, irritability, distrust of others. They can't respond well to social cues, lots of somatic complaints, difficulty with authority, redirection, criticism, and statements about death and dying. In middle school, you still see that irritability, lots of somatic complaints, of headaches, stomach aches, I don't feel good, I need to go to the nurse, I gotta go home, and also just repeated discussion of the event. Now in high school, this is where we start to see some very risky behaviors. So we see the increased risk of substance abuse and some of the really, I'm going to call it the self-destructive, impulsive, risk-taking behaviors. And you guys know these kids because you stay up at night worrying about these kids. And these kids can also have the repetitive thoughts and comments about death and dying. Now, complex trauma is a little different. Remember, complex trauma is repeated trauma in multiple domains of one's life, as well as usually perpetrated by a caregiver. Complex trauma will affect every domain of a child's functioning. And I'm going to try to go through these quickly. This is always a challenge for me. But I want you to think about the kids you work with. And you may be able to connect some of the symptomology and the functioning in the domains to the kids that you care about. These kids are uncertain about the reliability, predictability of the world. They're not sure they trust you're going to be there every single day for them. They come in with boundary problems. And boundaries are the distance between two people, usually emotional. So these are the kids that will walk into your office and will vomit their life story at your feet within 5 minutes of meeting you. This is the kid that walks into your office and says, "Hi, my name is so-and-so, I've never met you, I was sexually abused, my father's beating." They vomit their life story at your feet. You know these kids. The extreme opposite would be the kids that you work with for 4, 5, 6 years, and they never tell you anything. So there's a wall a mile high. We see a lot of distrust, suspiciousness, social isolation. The main way to heal from trauma is connection and relationship, but these children are socially isolated. They're socially isolated from peers, from adults, from caring adults, from their families. They are all alone in the world. We see a lot of interpersonal difficulties, troubles with peers, with all of you, with people in authority, and so they just struggle interpersonally. You know these kids, don't you? Difficulty attuning to others' emotional states. These are the kids that, you say, I wonder how Johnny felt when you smacked him in the face. And this is the kid that is not able to take the perspective of somebody else. So what do we do as adults? We say they have lack of empathy. Oh, we've got an antisocial kid. This is not an antisocial kid. This is not a kid with a lack of empathy. This is a kid that is unable, not unwilling, to take perspective. And they have difficulty enlisting others as allies. When they're calm, you could say, "Give me a call, come to my office. If you need to talk, I'm here." You say this to all the kids. But these are the kids that when they're in distress and in the crisis, do they come to you? Do they call you? They never do. The next domain is biology, and we've talked quite a bit through the ACE study. So we see a lot of sensory motor development problems. Sometimes we see analgesia, which is a high pain threshold. And you know, if I am ever being physically abused, I want to develop analgesia. I don't want to feel that pain. These are all adaptive coping mechanisms. We see a lot of problems with coordination, balance, body tone, difficulty localizing skin contact. These are the kids that go to the school nurse and say, I don't feel good. And the nurse says, tell me where it hurts. Well, I just don't feel good. So they're not able to say, there's a pain in my stomach, it's sharp versus dull, it's ongoing. They're not able to localize that. And so what do we think as adults? They're faking. And we send them back to class. Again, re-victimizing because we don't understand the dynamics of trauma. We see a lot of, I'm sorry, my voice is going, somaticization, which is a psychological process of turning emotional pain into physical ailments. So these children do have stomach aches, headaches. They do not feel good. Sometimes migraines. The next domain is affect regulation. We certainly see a lot of these particular symptoms. Difficulty with emotional self-regulation. They go from 0 to 60, and you don't even see the trigger. You don't know what happened. They just are off. You remember the brain scan? Remember there was nothing going on except in the brain stem? We have difficulty describing feelings and internal experiences. These children struggle with, are you happy, mad, sad, or glad? They know they're mad, but they don't know anything beyond mad. You guys know these kids. You guys work with these kids. You were working with these kids until last week. Difficulty communicating wishes and desires. Again, these children do not reach out when they need to and when they should. The next domain is disassociation. And disassociation is an altered state of consciousness. At its worst, or at its severe, at the severe end would be literally a splitting of personalities. But many of our traumatized children have periods and symptomology of disassociation. These are the kids that are staring at you and you know nobody's home. So they're staring glassy-eyed at you, but they're not taking anything in, and you know they're not taking anything in. These are the kids, the little space cadets that are staring out the window at all times. They can't pull themselves away from their daydreaming. These are the kids that will develop amnesia. And it may just be for small incidences of trauma, but it may be for large periods of time. If a child does not remember a large segment of their life, Houston, we have a problem. I always like to explain that before the age of about 5 or 6, children do not have cognitive memories. So if you don't remember anything before the age of 5 or 6, that is okay. You're not supposed to. All those memories are sensory. But after about the age of 6, children should remember what is happening to them. I worked with a young girl several years ago, and I loved her story. Actually, it was a very sad story, but I loved her story because of her description of disassociating. And any amount of stress would trigger her, and she described it. She said it's like Alice going down the rabbit hole. And she never knew how long she was going to be there. She didn't know if it was going to be for 20 minutes. She didn't know if it was going to be for 2 hours or 12 hours. She went down that rabbit hole, and she had no control when she came back and reconnected with her own humanity. The next is behavioral control. Difficulty modulating impulses. No delayed gratification. If I want it, I take it. These are the kids that will steal. And they'll steal things without any value. It is just difficulty modulating. They will fight. They can become very aggressive, either verbally or physically. They can become extremely self-destructive. The cutting, the burning, head banging. They can. We see a lot of pretty significant substance abuse. And, you know, before I worked at the court, I worked in community mental health. And I thought that I was being very sophisticated clinically because if a child came into the clinic who they were reporting an increase of behavioral problems, if the child was 12 or older, I would always assess for a substance use disorder. And people said, oh, you can't do that, you can't do that, you can't do that, they're too young. Working at the court, some of our data has indicated that upwards of 35% of our children have started using drugs and alcohol at age 8 to 10. Shall I say that again? 8 to 10. We don't even know the damage to the brain at that point. We only know the damage once they hit adolescence. So we see pathological self-soothing behaviors. In younger children, we can often see head banging, rocking, sucking. We can see excessive masturbation. So just anything to self-soothe. Remember, these children are not able to reach out to others to get their needs met. So they have to figure out how to self-soothe, and they are going to choose a pretty non-adaptive way. We see a lot of sleep disturbances, eating disturbances. Now, the one that you're probably scratching your head about is excessive compliance. How many of you, you guys are a pretty young group. How many of you have children? Or you're around children? Are children naturally compliant? No. No, they are not. Normative, healthy children are not compliant. So if you have a child that's excessively compliant, all the adults say, whew, at least they're not stealing and fighting, and they ignore that child. But if it is too scary to misbehave because of a trauma background, we have a problem. We see a lot of oppositional behavior, difficulty understanding and complying with the rules. If you want to piss off an adult, have a kid not follow the rules after you just told them what to do. And yet these children, it is not that they are unwilling to follow the rules, they're unable. Go back to that brain. They're unable. So they'll hear the rules, they'll even repeat them back to you, but they're not going to take that in and to be able to follow it. These are the kids we call volitional. These are the kids we call delinquent and defiant. These are kids I call traumatized. We also see reenactment of the trauma. Most commonly, we'll see that either sexual trauma or aggressive trauma. Cognition. You know these kids, don't you? You know these kids. Am I boring you guys with this? Is this something you guys already know?
No.
Okay. Oh, good. So cognition, difficulty with attention regulation. How many of your kids are diagnosed with ADHD? All of them.
Most of our staff, too. And our staff.
And staff, yes. Almost 30 years ago, I started my career working with victims of sexual assault, molest. And about 10 years after that, I started developing expertise in working with ADHD. And about 10 years after that, there's the connection. Because I was studying them as two separate areas. I do believe that a large percentage of our children have an ADHD diagnosis because of unidentified, untreated trauma. Don't even get me going on what a psychostimulant will do to a revved up brain. Don't even get me going there. So we also see a lack of sustained curiosity. What do kids need to do and have to be successful in school? They need to be curious. And normative children, those of you that have your own, you know how excited they are about learning. They're excited, they want to show it to you, they want to learn. They learn enormous amounts of information. But the traumatized child doesn't have curiosity. And if you don't have curiosity, eventually you're going to be pretty far behind. Problems with processing novel information. These kids don't transition well. So if it is, we're going to stop this activity and do some, we're going to get out of the boxing ring and we're going to go do math, these are the kids that struggle with that. They cannot transition well. They cannot transition well. Again, troubles focusing, completing tasks. What do you need to be successful in school? I mean, you need curiosity. You need to be able to plan. You need to be able to finish these tasks. These are all just the foundational basics. A problem with object constancy. These are the kids that they may not believe you're going to be there tomorrow. Maybe they have seen you every single day in the last year, but they don't trust you're going to be there tomorrow. Again, they never trust. Difficulty understanding the contribution to what happens to them. We certainly don't want to blame our traumatized children for making bad decisions. But part of the work we do after they've made a bad decision, as adults, we simply try to process that. You know, when this happened, what were you thinking? What could you have done differently? They're unable, not unwilling, they are unable to look at their own contribution. We see a lot of learning difficulties. I know you have a large percentage of your kids that probably are diagnosed with a learning disability, probably a communication disorder, either receptive or expressive communication disorders, difficulty with orientation in time and space, acoustic and visual perceptual problems. These are the kids that have a really distorted view of, for example, danger. So either they walk into your classroom and they're hyper-vigilant, hyper-aware, they're convinced something bad is going to happen, they're convinced they're in danger. Or it's the kid who walks at 3 a.m. into a street gang and has no fear. So it's a distortion in their perceptions. We do see a lot of difficulties in self-concept, especially with, children and then especially with adolescents. Really they're tasked to find out who they are and where they belong in the world. But without a consistent mirroring of caring adults, they don't know where they belong. Now, when we have a child that doesn't know where they belong, they have interpersonal difficulty problems, but they don't want to be alone. Where do these kids go? They find every delinquent in every corner. Some of them join street gangs. These are the places that will accept these kids. It is the one place these kids can be accepted. We see a poor sense of separateness. I often like to say blood is thicker than water, and a lot of our children will talk about, especially our juvenile justice involved kids. I can't tell you how many boys I've talked to, and they'll say, well, I really don't want to go to prison, but, both of my older brothers went to prison, my father went to prison, my uncles went to prison, my grandfather went to prison. I'm going to go to prison. And so it's not even a conscious choice. It's they don't have that sense of separateness. In child welfare, we have children that may have been removed for really egregious reasons. But what happens on their 18th birthday? They beeline right back to that family. So very, very poor sense of separateness. We see disturbed body image, extremely low self-esteem, shame and guilt. Guilt is the idea that I did something wrong. Shame is I am wrong. I'm inherently wrong. And these kids feel both. So how come in behavioral health we don't know about some of the trauma diagnoses, with the exception of maybe post-traumatic stress disorder? The reason we don't know is that the current classification in the DSM-5 inadequately describes the range of difficulties that traumatized children experience. So instead of getting a cohesive diagnosis so that everybody could read it and say, oh, we've got a traumatized child, instead we get a mishmash of all these diagnoses. So we get a lot of depression, mood or dysregulated mood disorders, anxiety disorders, disruptive behavior disorders, reactive attachment disorders, learning and communication disorders. Now, not surprisingly, these are the most common diagnoses that you just, well, I wonder what that's about.
It's probably the same for medical diagnosis, if you think about it.
For medical?
Yeah, because think of all the different medical problems that adults who had a lot of childhood trauma have. So they're getting diagnoses of substance abuse disorder, of depression, even of heart disease and that kind of stuff, and nobody's pulling all that together.
Nobody's fine. You can tell I've spent my career working with children. So adults are not clients, they're both parents in my world. Do you want to take over?
Okay, let's get back to trauma and learning. Here's just some of the things that you see show up in a learning situation in a classroom that gets in the way of children with a lot of childhood trauma, taking in the information and retaining the information and using that information. And Dr. Tobiasen already referred to some of it. They have difficulty just understanding cause and effect, taking in information, attending, paying attention, making plans, organizing their work, even following the rules, engaging in the curriculum, and of course, they have trouble regulating their emotions. So all of those are tied into, are they taking in any of the information that you need them to in a classroom setting? No. Kids with high trauma, childhood trauma scores tend to have lower scores on their standardized achievement tests. Why do you think that is?
They're not processing the information, or they don't have a lot of the skills that they need to stay focused.
Right.
Actually.
Right.
Or they get less anxiety.
Yes. So you've got both that they had problems taking in the information when they were learning it, and now they've also got test anxiety. That is really prevalent with kids with high. So even if they're doing well and they're engaging with a particular teacher in a class and they seem to have some passion for learning a topic, you put them in a test situation, especially a structured, scary one where there's timing and an authority figure watching you, and they go into a trauma state. And even if they do know a good portion of the information, they can't get it to show up. I'm the adopted parent of one of these children. She's a senior in high school. Just took the ACT for the second time. She has an ACE score of 7. In foster care twice, most of her childhood, 6 schools before we got her, and she was only in 2nd grade. And so we got her at 7. So same thing. She's doing so much better. She's learning so many ways to bring in information. She knows she has trouble focusing. She knows what triggers her trauma that keeps her from learning. But still, you put her in a testing situation, and even if she knows the material, so we've really done a lot of work with her about just what to do in that testing situation, and for her to take control. What do you do when they say there's 20 minutes? What do you do when you say 5? So it gives her some cues for her to actually stop and think about what she's doing. So hopefully this score will be higher than the other one. We'll see. She's scared, she said, to see her score. They're more like kids with high trauma scores are far more likely to be retained in a lower grade. What will be the difference if they get kept back? Is the trauma going to go away just because they're repeating the year? Probably not a good approach. Obviously more likely to drop out, and Big one, more likely to have problems in receptive and expressive language. That's pretty vital in education, especially if you're moving into higher education. We like this quote. All right, so the traditional view of kids with some of these problems in all these domains that Dr. Tobias was just talking about is that they've got anger management problems. There's the ADHD, that they're volitionally acting out, they're choosing to act out. That they're uncontrollable kids, destructive, non-responsive, and the traditional response is they need consequences, or they need an ADHD diagnosis and some meds. The more trauma-informed view is that they have difficulty regulating their emotions, maintaining focus. They don't have the skills necessary because of their impacted neurobiology. It literally does change brain structure, childhood trauma. It literally changes brain structure. Does that mean they're doomed to never be able to learn? No. We know plenty of people with high ACE scores who have been successful and have a passion for a career and have done quite well and not had some of those problems, but their brain is still changed and they had to learn a different way. My daughter, on one of her college applications, on the personal statement question about what kind of adversity have you experienced, she actually wrote about the adverse childhood experience study, her score, what that's done to her. She knows her brain works differently, and what she's done, because she knows her brain works differently, to get her grades higher and higher every year. So she can even see that it's possible, even though she knows her brain works differently, to do good work and better work than some of her fellow students. Do we want you to be therapists? No. Kind of feels like it today, though, doesn't it? No, we don't want you to be therapists. A therapist is someone who's a licensed clinical mental health professional, like Dr. Bison. Those interventions typically occur on a one-on-one basis. They're emerging approaches to treating trauma all the time. There's not one thing called trauma therapy, that's not a thing, although I used to think it was. But there's lots of different approaches of trauma that are trauma-informed. Cognitive behavioral therapies are really good therapy, very effective for adolescents. When you make it trauma-focused cognitive behavioral therapy, the outcomes increase by quite a lot. So there's lots of good therapeutic approaches. And it focuses not just on the trauma, but the reactions and how to reduce the symptoms, because that's what it comes down to. What happens to you because of that childhood trauma? What are the symptoms that you have, and how do we reduce those symptoms? We reduce them sometimes by eliminating the triggers or helping you recognize the triggers and then know what to do if you're triggered. So the approach from the school, who's not a therapist, is just to be educated, be aware, be sensitive, make accommodations for kids like this, and focus on the student's educational success through emotional and physical safety, empowerment, trust, choice, and collaboration. So we'll elaborate more on some of those approaches. Love this one. Kids who are loved at home come to school to learn. Kids, those who are not, come to school to be loved. So if they're showing up for that reason, that's awesome. Let's take advantage of that and also help them learn. Dr. Bison said this: healing from trauma can only occur in the context of a relationship. If that relationship is their primary caregiver at home, that's the best. But if it's not, if it's you, it still works. Lincoln High School. There is a video about this high school called Paper Tigers. Has anybody seen it? Seen it? It's amazing. Anybody else? Washington High School, have seen it? In Walla Walla. They did one, the kids later too, after some of them went to college, to show where they're at. But actually follows these kids. The principal there, Jim Sporlitter, wanted to become a trauma-responsive high school. And it was an alternative high school, lots of behavioral problems, lots of suspensions. You can see before, when he learned about childhood trauma and the ACE study and how to approach kids with brains that had been traumatized in a learning situation. He decided to implement across the board from everybody, from the security guards to the principal and all the teachers, everybody in between, to be trauma responsive to the kids. They went from having almost 800 suspensions in one school year, or the days the kids were suspended, to just 135 days, 50 expulsions to 30. It was amazing in just 1 year what they did, and they've gotten better every year. If you can watch that video, please do. Schools, K through 12 can get it really cheap, can buy it very cheaply. We were able to buy it because we have a school at the juvenile court for the kids in detention. We were able to buy one for the court. Here's some of the things that have come out of the study of schools that have decided to become trauma informed. Everything's gone up. Improved academics and test scores, the climate, the teacher satisfaction, safety, everybody feels safer, absences have gone down, stress has gone down, and dropouts, of course, have been reduced. Those are all things that save money, too, by the way.
Are there any schools in Tucson that are implementing this success?
I think there is one TUSD school that has decided they're going to be a trauma responsive school. I don't know exactly who they are yet. I'm not allowed to say, I guess. But Rincon High School actually does the ACE, does an ACE score on every incoming freshman, starting this year. They started doing that. And now they're trying to incorporate that into their curriculum and working with their kids there. Yeah.
And there in Tully Elementary is pulling in a lot of trauma informed components.
Yeah, they're doing a peer court, Tully Elementary, into USD over in El Rio area. They're doing a peer court, so the kids are actually being judges and attorneys and working on restorative justice with kids who have behavioral problems and getting in trouble at school. And they're using a social emotional learning, I'm forgetting the name.
A curriculum I have too.
There's a curriculum that just got it. Every teacher is, Sanford Harmony. Yeah, it was developed out of ASU, Sanford Harmony, social emotional learning. The teachers just do some things, 15 minutes, once or twice a week. And the curriculum, their games and discussions and group activities and stuff like that. So, and you had one more question.
And I'd like to say everything I've heard of your school, you're doing a lot of components already and have been for quite some time.
Can you touch briefly on childhood psychosis or schizophrenia? Does it have the same symptoms of trauma? And is it caused by trauma or is it entirely different altogether?
Oh, let me take this one.
You have to take this one.
Excuse me. Often when we first see childhood psychosis, it's very, very scary, but the first thing we have to rule out is whether it's anxiety-based. So that would be probably related to some kind of trauma. If it is not anxiety-based, then we look at a genetic component. Are there people in the family? It's pretty, childhood psychosis is pretty rare. It is rare before the age of 18, but we definitely see it. And I know I've seen more childhood psychosis working at the court than I ever did in community mental health. But the first place we should always go when we see a kid who is presenting with any kind of psychosis is anxiety. Did that answer your question?
So the ABCs of first aid, right? So this is kind of the psychological first aid. If you think a child, one of your students, one of the kids you're working with has been triggered and they're having some kind of trauma response, very simple initial approach with them is just listen, let them tell you what's going on when they can speak, protect them. The foundation of all adverse childhood experience, of all trauma, is a lack of safety. When you do not feel safe, can you do anything else? Can you focus in the classroom? Can you have a conversation? Can you do anything if you don't feel safe? Basic human nature. the need to feel safe. So you can help them feel safe, get them to a place where you know that they feel safe, and then make some kind of connection with them so that they remember you, they remember your name, they remember you said, come talk to me. Even if they don't do it right away, you connected with them. So just make some kind of personal connection. So that's a way, if you've got a kid who's in some kind of trauma reaction. Attachment, self-regulation, competence, that's the ARC model. That's how you help children develop competence even under adverse conditions. So you can read about it, it's Maston Coatsworth. It comes from the National Council of Trauma, National Center for Trauma Stress Network, Childhood Stress Network, sorry. Let's go past that one. Okay. There's lots of different teaching approaches actually that are being used out there. There's one called Islands of Competence, really just helping and encouraging a child to find that one island where they feel especially competent. And you have to keep trying and asking questions and watching them and helping them explore until they find it. I'm sure you've seen these kind of kids. Once they find their thing, something changes for them, right? The principal at my daughter's school actually said that to her when she had a terrible freshman year. He says, you need to have something here. Something needs to be yours here at the school. You can't just show up to classes. You need to feel like something is yours. And he talked about some kids he had known who had found things like dance, things like that. And she did. She started playing softball and was good at it, and that was her little island of competence. She took an art class, kind of another little island. So you keep finding these islands and you build them up that way. That's helping that brain structure. Predictability is huge with kids with lots of trauma. They need to have an established routine and positive responses. Communicate about the schedule often. They don't like surprises. They don't like changes to the curriculum. Fire drills are disastrous for kids with trauma. Transitions always hard. I mean, you know, if you've had kids yourself, and when they're little, transitions are always the hardest thing, right? No, we're going to stop playing this now and wash our hands and eat dinner. No, we're going to stop reading a story and go to sleep. Just transitioning from one thing to another is hard enough when you're a little kid. But transitions for kids who have trauma histories can be particularly difficult, especially if they're in a middle school or high school where they change classes and they're in the hallway. So lots can happen on that journey from one class to another. So help them predict what comes next. Safety, again, is everything. Physical safety, psychological safety. Help them always feel safe whenever you can. Teaching conflict resolution skills. That's why Tully is doing the peer corps, because they're learning how to resolve conflict among themselves without the principal taking care of things for them. And so they're learning conflict resolution, mediation, that kind of stuff. Written plans, of course, building in accommodations. You can build in accommodations for kids with trauma reactions. For teachers, multiple ways to present. So you have to have, if you can have them repeat it back to you, although don't call on them. Most of the time that will trigger a kid with trauma history. Don't call on them. They have to, if you're just on a one-on-one situation like tutoring or something, then you can have them repeat it back to you. But calling on them in class when they, you can just press stop. Calling on them in class when they didn't expect it can really throw them off. Sorry, I had a timer set. Go over new material prior to the lesson, put information in context. It's always good to give examples from concrete to abstract, because they're the way that their brains think. They need to have an actual picture of what you're talking about. Identify and process feelings. Sorry, we're kind of rushing at this because we really want to make sure we have lots of time for the vicarious trauma. The fun stuff that we're going to do after a little bit of a break from this. Do you use PBIS? Yes, very common, very, very related to trauma-informed care. And this is just a little graphic to show you how the concepts, the key areas of PBIS really align with safety, empowerment, collaboration, trust, choice that are the foundation for trauma-responsive education.
And as we've been training, we've often heard trauma-informed care is the missing piece in PBIS. It's the missing piece, so.
We understand that you have done this before, so does everybody know about this iceberg exercise? So we won't go through it. Okay, so, but it really, doesn't it align with what we've been talking about? What you're seeing here is just the tip, right? Here's the childhood trauma down here at the very bottom. And here's, up here is what triggered the trauma reaction that caused this outcome and this behavior. What can you do? Just recognize that their behavior might be secondary to a trauma reaction. So the three reactions are fight, flight, you've heard that before, and freeze. Not as common, but it's real. That's my daughter's reaction. She freezes. It's not just her personally, physically freezing. Her brain isn't working. So if there's a teacher yelling or some kind of altercation, it's about 20 minutes before her brain comes back. She literally cannot take in information. She appears to be there and looking, but she's not bringing in any information. So just be aware that, and then the same thing, if they're fighting or fleeing, same thing might be happening. Understand they can't always express their feelings the way that we talk about feelings. They haven't learned to do that yet. It's amazing when they are educated themselves. I was kind of scared to tell my daughter about the ACE study for fear that she'd think she was doomed. And she did not have that reaction. I really saw her say, hey, this makes sense to me. So why wouldn't you want to know? Would you want to hide if somebody had a diagnosis of a child got diagnosed with diabetes? Would you want to hide from them what was happening and how they treat it? Why would you do that? So same thing with kids with trauma histories. Making connections, everything, and I know that's what you already do here. Sense of safety, not just physically, emotional safety at the school and wherever there are daily routine. Reduce trauma reminders. It's hard to tell what those are because if you don't know what trauma the child has, but you can always guess because you know what some of the big things are, right? So lots of kids have been exposed to domestic violence. So if something violent happens at school, a lot of kids are going to be triggered, whether they were involved in it or just saw it happen or even hearing after school that it happened.
Or perception of disrespect.
Common respectful demeanor, really hard to do. That's even hard to do as a parent sometimes because we're having a hard day. We don't feel good some days. A whole bunch of kids act out on us. Really hard to maintain that, but do your best because it makes a difference. Teach the students self-care just the way you're going to learn it or you have learned it. Help them see that connection between their behavior and the consequences. That isn't always clear, kids. And teach them over and over again. They're not going to learn it the first time, the second time, or the third time. Teach them in multiple ways. I've used a lot of tutors, and they use lots of different methods. And the more ways that she's exposed to information, the more likely it's going to stick. What else? Increase your own awareness. You've done that. Break down expectations into small bits. Lots of goal setting, and individual goal setting is really good, I think. These kids sometimes have a hard time seeing themselves, let alone in a month, but in a lifetime, like what kind of career they might have. They just can't even picture themselves doing something as an adult. So goal setting actually helps them have a picture of themselves. Even if they're not 100% sure they can do it, they actually have had that vision of themselves. Keep everything in perspective, positive self-view, healthy adult relationships. Reinforce those with the kids because they're not going to have maybe that at home or anywhere else in their life. Remember, it's not about you. That disrespect is an adaptive response. Remember, it's not volitional, it's functional for them. Advocate for community intervention. Treatment does work. I'm not going to say we have the best cutting edge, gold standard community mental health treatment in Tucson, Arizona, but we have pockets of it. And if you get them started somewhere, eventually they might get to somebody who really knows what they're doing. That's one of the things we've been working on, is trying to increase the number of trauma-responsive and evidence-based services that are available, and increase those with our behavioral health provider, Simpatico, in Pima County. Resiliency, and we're going to talk some more about that. Got to believe that it's true, and it is true. I met Dr. Felitti one time, and we said, well, what do we do with all this? I mean, how do we help these kids? He said, that's not my job. I just do the study to show what the predictions are for them. He really doesn't have any interest in working on resiliency. So other researchers have taken up that task and working on that. This is one of the tools that Jim Sporleader uses in that Lincoln High School, that the Paper Tigers. Knowing that some kids, when they're in a trauma state, cannot have a conversation with you. Have you experienced that? Either they're grunting, I mean, a lot of teenagers do that anyway, or they're just not answering you. You can't have a conversation. It's because they don't feel safe, and it's because the cognitive part of their brain isn't working at the moment because they're in a trauma state. But visuals sometimes really work, especially very colorful ones. So he sits down with them when they first come to his office, and he says, point to where you're at. And they know that the red means they're having a hard time with their feelings. And so if they're in red, they just get to sit there. And he lets them do something that will help them relax and calm down and let their brain come back so that they can have a conversation. They can point to yellow, they're calming down, they're not quite calm enough yet, so he knows they're at least going in a good direction. If they don't get there, he does something else. And finally, they point to this, I'm ready to learn. That means they can go back to class, or they can have a conversation with him. Here's more ideas that other teachers and educators and people who work in schools have come up. Greet every student every day at the front door, and at the end of the day, say goodbye. Very personal. Emotionally grounding rituals. A lot of elementary schools do this with the music that plays in the beginning, or have music playing between classes. Eliminate intercom messages. It's amazing. Has that ever triggered anybody when you hear the intercom come on in class? Yeah. Most kids don't have any reaction to that, but a lot do. And it's scary because it's unpredictable, and where's that voice coming from? So a lot of schools have gone from not even having those, and they just walk a message. Luckily, my daughter's high school just sends somebody with a message. They don't get on an intercom. It's hard to really do anything about fire drills, though, isn't it? Have one person adopt that student. It sounds like you already take that kind of approach, where they have one primary person they can go to. Focus on teaching behavior rather than disciplining. So instead of teaching them what not to do, focus on teaching them what to do. Connect before correct. It's not going to have as much effect if you go instantly to a corrective action with a child without making any kind of personal connection with them. Let them see you as a human being who is there to support them, even if there is going to be a consequence because you don't have a choice. And their behavior put them in that situation. Still make some kind of connection, and it will have so much more meaning than just the consequence without a connection. That little pencil, do you want to talk about that? So the principal, do you want to describe what it is?
One school adopted where teachers were given just a standard pencil, and if they saw a child start to escalate, either go into the fight, flight, or freeze mode, they'd say, Johnny, I borrowed this pencil from the principal. Can you take this to the principal for me? And the child will pick it up and will walk. The principal will know what the cue is because of the pencil, and will say, I'm not ready for you right now, but I've got a rock garden here or a sand garden here. Can you redevelop the sand in the garden? It's that grounding ritual. And they're able to self-calm. So I thought that one was a pretty significant intervention.
This one about put your hands up, they do this over at Project More. We actually watched the principal do it with all the teaching staff when we were presenting. He just stands there and puts his hand up. He doesn't say, hey, and doesn't yell, pay attention, let's get started. And then somebody else notices he's doing it, and they do it too, and it's all silent. And eventually the whole room's silent, and they just have their hands up. Much calmer than yelling. Hit and run is really just walking by somebody and saying something nice to them and keep going, because sometimes they can't accept, they don't want to have a conversation, it scares them to engage, If you walk up and say, how are things going, or I thought you did really well the other day in that presentation that you did, they don't want to talk about that. But if you just say it real quick and walk right by, gives them a chance to take that in without being scared that they have to engage with you. Water and snacks, food, all that stuff, because safety is primary. All those other basic needs are primary too. So when you address all of those, remember the whole Maslow hierarchy of needs, what's at the bottom? Basic needs. Safety, food, air, water. If you have all those, you can at least start from there. We talked about some of these schools. Massachusetts has a statewide safe and supportive schools going on, evidence-based practices, trauma-informed communities. There's a whole bunch of examples, and we've got links at the end of the PowerPoint and in your handout, so you can go look that up. We actually created an action plan for the school in TUSD that wants to become trauma responsive. I think it's the first action plan in Tucson, so I don't even know how they're doing with it. But there's other schools who have done that. I love this. This is new. Some key components of resilience. So resilience is what counteracts childhood trauma. Some of that resilience is built in, right? Have you known people that seem particularly resilient? Part of that might be their personality, but you can build that in. You can help them become more resilient by addressing it from different approaches. So community, culture, and spirituality. So these are sort of cultural traditions, rituals, engagement with a culture. Of course, any kind of faith community would have this, but any kind of engagement with a pro-social group, a kid who's involved in boxing or in some kind of sports, that's a pro-social group. But that tie to community or to their own culture, our local Native American tribes and nations do that really well, that they try to bring kids back into the culture and the traditions of their cultures, and that builds resiliency. You can also build resiliency through attachment and belonging. So it should, and we hope it comes from their parents or their caregivers, but any nurturing and competent adult. So 50 people sitting right here. Of course, friends or romantic partners would also provide that sense of security and belonging. And then the third domain for resilience is capability. So every skill and every little bit of knowledge that they gain builds their resiliency. One of the best predictors of a kid being resilient is them having high grades. So the grades themselves give them more resiliency. So if you can get a kid to get really good grades one time, and they see what that feels like, they can build on that. So here's what came out of Washington. They're now starting to do some looking at outcomes for kids with A scores. So they've been implementing some resiliency building programs into their school. So, and into their communities, actually. So under those three domains that we talked about. So they're now watching these kids to see, with kids with high A scores, who did receive some of these higher levels of resilience, how likely they were to graduate from college. So they're following them that far. So the orange bars are the kids who had low support and hope. So in other words, they didn't get that built-in resiliency, any of those things that we talked about in those three domains. This one is the kids who did receive that, high support and hope. So they're measuring how much the kids get from their community, their culture, their parents, their relationships, their own accomplishments. And that predicts, despite the fact that they have the same number of A scores. So here's the kids who have no A scores. So if they still have no A scores and low support and hope, only 25% are going to graduate from college. 40% of those 0 A scores will graduate if they have the high support and hope, those resiliency factors. Now here's the kids with 1 to 3 ACEs, and here's the kids with 4 to 8. So that's pretty impressive. I mean, 4 to 8 ACEs, and they've still got 20% graduating from college. But look what you do with even that high ACE score. You've got 35% of kids graduating from college because they had those resiliency factors. They had that high support and hope. It's more than the ones, the 0 to 3, who didn't. So that shows you that ACE score is not dooming people. What dooms them is if they have a high ACE score and no support and no hope. That's what it comes down to. Can you talk for a minute about what you're already doing that we've talked about? Examples of things, approaches that you use either on individual or across the board approach to kids that aligns with what we've been talking about to work with these kids? How do they know that you care?
I think it's just like the way the programs ran. Certain things are run. Listening, paying attention to them, making sure that they're getting their voice, and it's like a certain time that
Choice, yeah.
they also
Choice
do
of
this. The RTE team is also very
What's that?
the RTE team is also very individualized. Each one of the students, especially with our students, so they get a chance to have a one-on-one time with our staff members.
Okay, connection. Good. Those are great examples.
Every child that comes in the front door is a beautiful person.
You're already doing that? Connection. And they're valued. They value. They belong here. They feel safe. That's a lot. It's amazing what you can do with just that one thing. It doesn't cost anything.
And just to make a shout out to what he said, our RTE team is sort of like roving psychologists, even though they're not. Anytime a child is starting to go into some sort of emotional distress, they're really calling there within like seconds to work with that kid. And so it's really beneficial.
Perfect. Yep.
We use de-escalation techniques, and then we do like mindfulness exercises for the kids, like the breathing exercises. Instead of yelling at them, we tell them to breathe, relax, or we tell them to walk with us.
And now that you've seen the information that Dr. Tobiasen gave you about how their brains work and how their brains have changed, you can see how mindfulness would work, right? That's the way they get their brain to start working again, because it's structured differently than the rest of us. Some folks can have something happen, like you know, if there was a fire drill, you go out and fire drill, come back, you sit down, and you start doing your lesson again. That's the way their brain works. Another child can't get back to it for 20 minutes because they had that reaction. So whenever the mindfulness would be a way to approach that. If you could teach a child to do that themselves, with any kind of mindfulness approach or deep breathing, meditation, any of those things, they can get themselves back in a learning state by themselves. This is really what it comes down to. You don't remember anything else. What we teach everybody is if you just listen and be kind, you're going to be helpful to anybody who has childhood trauma, who's being triggered. At the court, we use a universal precautions approach. Did you ever have to get trained in bloodborne pathogens and what you do if there's bodily fluids, to make sure you wear gloves, you have to clean up a certain way, clean with bleach, that kind of stuff. Those are universal precautions to make sure no bloodborne pathogens are transmitted. You're assuming that those bodily fluids contain things like hepatitis or HIV, right? That you're assuming everybody might have that in their blood. That's the universal precautions. At the court, we assume every single person who walks in the door, including the staff, has childhood trauma. And so we approach them all the same way to make sure that we don't trigger them. And what that really comes down to for some of our staff, especially receptionists, is listen and be kind, and they're way ahead of the game. So let's take a short break, and we'll get to the vicarious trauma portion, which will be fun.
Oh, look, it's us again. Thank you for the throat lozenges. For the rest of the afternoon, we're going to be talking about vicarious trauma. Does everybody have 2 packets? One that says vicarious trauma on the front, and another, there should be an envelope. Okay, good. If you don't have it, let us know and we'll get you one. I started studying and training on vicarious trauma over 20 years ago. And every time I taught, every time Chris and I teach, it can be a pretty emotional experience for many people. Why don't we get moving?
I'm so engaged with you.
You know, we're going to be using terms vicarious trauma, secondary trauma, compassion fatigue. We will define each of them, but sometimes we use them interchangeably. But everybody in this room is in this work because you have a calling. You don't have a choice not to be here. We're here because we're passionate. We're here because we care. We had no choice but to be here working with children. And many of us are here because of our own trauma histories. So that which makes us good and committed to this work is also what makes it challenging. The definitions, vicarious or secondary trauma, those are going to be the changes within the helper because of the work with traumatized children. You are exposed to trauma material of the kids day in and day out, and it will change, and I'm saying it will. It will change your feelings, your personal relationships, and your worldview. Now, compassion fatigue is a little bit different, because compassion fatigue is working with lots of trauma material and then eventually kind of losing your compassion or losing your empathy. I see this sometimes in law enforcement. Sometimes we see some pretty egregious descriptions of what law enforcement officers do when they're faced with additional stress. This is different from burnout. Burnout is too much work, not enough resources, not adequate supportive supervision, and you just get tired. You become exhausted, you disengage, and some of us go through this where we're feeling this at different times, and then we reconnect. And that is different than countertransference, which is a psychological term. And countertransference is really how we respond to our own unresolved issues. And the 2 most common ways that we respond is that we become over-involved with a child, or we avoid. So we disengage and avoid. Now, there's been quite a bit of research on the effects of different helpers with the vicarious trauma symptomology. You can see right smack in the middle, educators. But what we do know is anybody that works with traumatized children will experience some of the signs and symptoms. You know, this, I generally don't like to read long quotes, and this is actually an old one, but I think it is so important. When we working with the injured, we enter what I can best describe as a twilight world. This world alters our perceptions of daily events, and even more disturbingly, may change our inner lives, sometimes irrevocably. What we see when we walk down the street, what we fantasize, feel, and fear often differs markedly from the experience of others who do not experience the world in which we immerse ourselves. We have all chosen to immerse ourselves in the dark underbelly of life. We see egregious trauma material every single day. Now, some of the characteristics that add to this stress is that we work with students and parents who can be resistant. They can be demanding, hostile. They can present with education interfering behaviors. They can relate stories of trauma, including real human cruelty. And sometimes our students can be both victims and perpetrators of the trauma. Now, these are occupational hazards. We're going to be talking about how each of us, each of you, has been, will be affected by this work. But our reactions are normal reactions to working with this kind of population. They didn't tell us about this. Did anybody get information in your educational program on vicarious trauma? That would be a no. Personal impacts, we live with them in isolation. There can often be shame around. How come I can't handle this and everybody around me can? So we suffer these effects in isolation. The personal impacts are often cumulative. They will change your belief over time. And the effects are often permanent. They're often permanent, resulting in changes to how one perceives the world. And when we get there, I'll talk about how my world perception has changed significantly through the work I do. But again, these are normal reactions. There is nothing, this is nothing about you being lesser than your colleagues. These are normal reactions. And again, why didn't they tell us about this in our educational program? Boy, they taught us everything else and then they drop-kicked us to the wolves.
So there's kind of phases of compassion fatigue. I think you might recognize this. Think back to when you first, especially those who've been working in the helping professions for a long time, try to remember when you first got into it, you were going to save the world, right? I started in child welfare and I definitely was in this, I'm a superhero, I'm going to save all these kids from abuse and neglect. You're committed, you're ready to make a difference, you're ready to solve problems, and you're going to just have this I can do it attitude. It's a bit of a setup. So that's before the compassion fatigue sets in. Now the first phase of compassion fatigue after that zealot phase is sort of over is this irritability that might develop. So you've probably felt this yourself. You've seen it happen with coworkers. Someone starts to cut corners. They're avoiding about the students that they don't want to deal with, even though they feel like they're doing really good work with other students. They're avoiding some other students. That's mocking of people. This happened so much when I was working at CPS. We did this all the time. Part of it was sort of that black humor, you know, getting off steam after we'd had a lot of things happen to us, but it was kind of shocking when I was a new worker to hear what some of the other workers were saying about the families that we were working with. Using humor, not necessarily in an appropriate way, just being distracted, daydreaming a little bit, not listening to the kids when they're talking to us, avoiding conversations with people, especially parents. I definitely started doing that. Start to make mistakes, oversights, not concentrating on what you're doing, and then distancing yourself from those very people who would understand what was going on with you, who could support you, and that's your own colleagues and coworkers, maybe even your friends. Then you might move into the withdrawal phase. Now you've really kind of lost your ideal. You can't quite remember why you ever got into this. You've lost that passion. You're seeing all the students as one big blur. You put them into broad categories of those kids who do that and those kids who always do that. A child behaves a certain way and you treat them the same way you've taught every other kid to behave that way, because now you've put them into category. They've blurred together. Definitely did this in child welfare. I mean, I would see workers who put every mother who had a substance-exposed newborn into one category. It wasn't a good one. No compassion there. no matter what the circumstances were. You no longer see the kids as individuals. Maybe they're even irritants to you. Now it starts to leak over into your personal life if it hasn't already, where it's starting to affect your relationships at home, even with your colleagues, and you're numbing to block the pain and sadness. You're doing some kind of numbing computer game, like happy hour. This isn't a good one. Zombie phase. This is where that hopelessness, that sort of loss of passion now goes all the way to the other end of anger, and it's not anger at what happened to the kids you're working with, but anger at the kids themselves and their families, and even your coworkers. You start hating everyone. You're hearing your colleagues questioning you, or hearing that they're, if you're a supervisor, coming to you and telling you their concerns about some burned out workers. You're starting to think everybody else is incompetent. I remember somebody I worked with called everybody incompetent. It was just his favorite adjective to use, and it was definitely a sign and a symptom of his being in this phase of compassion fatigue. Having a real disdain for the people you're working with. Should anybody still be working with a population that they have disdain for? Why would you? And just think how destructive it is, not just to the families that are working with you, but to everybody around you who still has that passion, and then they have to watch you approaching from this position of disdain, and then just running out of patience. So you reach a point where you take one road or the other, the rocky road uphill with all the roots in the road, or the smoother, calmer road right there, and it really just comes down to pathology versus renewal. So do you give in to pathology, leave the profession? I know so many people in child welfare who have so many physical ailments, and they're just kind of a wreck. Their bodies are train wrecks, and they just keep working. And they're developing all these things. They've got back problems, and they've got blood sugar problems, and they've got immune system problems, and their bodies are just giving in, and that's that pathology. And they're just always ill and never feeling good. So the other choice is renewal, and that's where you begin to rebuild your resilience, re-engage in self-care, whatever you would, people just let that go. It's the easiest thing to let go when you're busy. Whatever you're doing for yourself is always the first thing that you let go if you're in the helping professions. So if you're working 50 hours and there's a crisis and you're exhausted and you have things going on at home, high chance you're going to take care of what's going on with the kid, no matter what's going on with you and your personal life. And that can really be destructive. Rather, yes, it might be what that child needs right now, but does it have to be you? And you have to give up on all of your self-care. Why are we always the first people that we shortchange? Why are you always the first person you shortchange before any of these folks that you're helping? Professional development, doing things like that's how you build resilience. Something new, learn something new, get more tools, see a different way to look at what you're doing, a new approach, some new research that's going on, some encouragement that others know what's happening with you. Re-engage in curiosity. So what else can I learn? What else can I do? What are other approaches I can use? And that's what you're already doing.
Compassion fatigue is a bit different than vicarious trauma. You know me. It's all about signs and symptoms in the domains. These are the most common signs and symptoms of vicarious trauma. And I do believe in my almost 30 years, I think I've experienced every single one of them. So as I go through these, think about where you are right now, think about where you've been in the past, and whether you've experienced any of these, whether you attribute it to vicarious trauma or not. So the most common signs and symptoms in the cognitive domain would be troubles concentrating. You're just having troubles concentrating on what needs to happen. There can be a suspicion of others' motives and behaviors. Chris worked in child welfare for a long time. Do you think she could go into Walmart and not see child abuse and neglect? Can't do it. I work with a lot of probation officers, obviously. And, you know, when I see an ice cream truck, I think Rocket Pops. If you ask a PO or law enforcement or attorney what they see drug dealers and pedophiles. So it's not uncommon for us to become very, very suspicious of others' motivations and intent and their behaviors. We can become very self-critical. I call it the woulda, coulda, shouldas. That is, you know, I should have done more, I could have done more, I didn't do more for this child. The woulda, coulda, shouldas. There was a wonderful psychological theorist, Albert Ellis, for those that may know him, who used to refer to it as masturbation. I must do, I must, I must, I must. So it's beating up on yourself for not doing enough. We see a lot of decreased self-esteem. Why am I even in this field? I'm not making a difference. We see apathy. I have nothing else to give. There's nothing else I have to give. Sometimes we see rigidity or perfectionism, and that is, I'm going to do the exact same thing every single time, or all my reports are going to be in because it gives me a sense of control and completion. So I'm going to ignore the kids, but boy, my paperwork is there. My paperwork is where it needs to be. We can sometimes really minimize, and especially when we work with such egregious situations in our children, we can find ourselves saying, well, it's not that bad. We've known worse. So we can really minimize what some of these kids are going through. And then we can also become preoccupied. I don't become preoccupied very often, but I always know I'm preoccupied when it's 3 a.m. and I wake up and I can't sleep because I'm ruminating about a kid. You know, what can I, the shoulda, coulda, wouldas, the masturbation. So I become preoccupied. Some of the most common behavioral signs: impatience. If anybody has ever seen me at a CFT, you know impatience. I have no patience for anybody who is not doing the best for children. And I'm extremely vocal about it. I'm very irritable about it because we need to do the best for these kids every single time. Sometimes we become withdrawn or moody. Sleep disturbances. Sometimes we have troubles falling asleep, staying asleep, feeling rested in the morning because our sleep is disturbed. We certainly see appetite changes. Some people, when they're stressed, overeat. Some people quit eating. So again, we can see some real disturbances in some really basic foundational pieces of our functioning. Sometimes we can become very hypervigilant. I live in Green Valley. For those of you that don't know Green Valley, it is the safest community in the Southwest. We're a bunch of old retired people. I'm afraid to go to the ATM at night. That is the hypervigilance from reading court reports and seeing what some of these kids do. I can walk almost any place in the court, and if I pound my hand on a table, half the people will startle. Or if I peek my head in somebody's office and they don't see me coming, they'll startle. Again, the hypervigilance is also the people that will walk into a public room and position themselves so that they can always get out. They can always see the entrance, the exit, and they always have an escape route. So these are all just very, very common signs and symptoms of vicarious trauma. Sometimes we become accident prone, we lose things, excuse me, and sometimes we regress. Again, many of us come from trauma histories, and we work through many of our traumas, but we find ourselves regressing. And that's when you gotta say, oh man, I thought I'd handled that. Well, you did handle it. It's just shown back up. Are these sounding familiar to a couple of you that you can admit? We also have very, very common emotional signs and symptoms. First is feeling powerlessness. So often we feel powerless in being able to adequately help the kids we're working with. We can do everything we can within our role, everything we can, but it feels like we don't have power to make a change. We can feel lots of anxiety. It's usually when I'm waking up in the middle of the night preoccupied, it's usually my anxiety that's waking up, worried about a child. What's going to happen? We can feel guilt. Again, part of that is, did I do enough? But some of it can also be a survivor guilt. We have one woman who has an ACE score of 0. And so some people will say, you know, I may have had it bad, but nothing like this. Nothing like this. I can't imagine that child living through that. So we can feel guilt for surviving. Lots of anger, lots of rage. We can shut down. We can feel numbness. We can feel fear. We can have intrusive images and thoughts. And again, part of those images and thoughts would be, for example, when Chris goes into a Walmart, she's not walking in and assessing whether children are being abused and neglected. Those thoughts are intrusive. They just show up. I had one friend early in my career, we did the same kind of work, so working with sexual victims, I should say sexual victim survivors. And the one place that she was able to feel calm was in her church. But because she knew the stats, she would sit in the pew and count people off. You're a victim. You're a victim. You're a victim. She couldn't help herself. These are intrusive thoughts. We can have a feeling of helplessness, sadness, depression. We can be on an emotional roller coaster. We can feel depleted, overly sensitive. It took me a long time to realize I don't own a TV. I can't watch the news. Periodically, I will see something that will take me to my knees. My significant other laughs at me because the only movies I want to watch are animated because I can't handle oh, we're nodding back there. Yeah. Because I can't handle the drama of so much media. One of the last times I really lost it was, do you remember several years ago the young children were coming across the border unaccompanied? They were very young, they were being held in the detention center. And I remember just seeing a photograph of these children wrapped in Mylar blankets. And I just kept thinking, oh my God, they're baked potatoes. Took me to my knees. I can't imagine a young child in a foreign country in a detention center, away from family, away from everything. I just could not grasp that. So periodically, and it always hits at weird times, I never get to plan, but it does happen. And then of course a reactivation of your own issues, especially if one of the children you're working with has a similar background to your own. Now there are also some pretty common signs and symptoms in personal relationships. So much of our work is confidential. And so we're really not able to go home and talk about the details of these children. Well, the way that we maintain intimacy with family, significant others, is through communication and sharing. So we can start to feel very, very withdrawn. There can be a decreased interest in intimacy. And again, it's because you're not sharing your whole life. There can be mistrust, lots of isolation. We can become overprotective. How many of you have kids again? Do you allow them to spend the night with friends you've never met? Are you going to say, over my dead body?
I don't sleep over even at the friends that they know.
Oh. So we tend to become extremely overprotective, and especially of our own children, but even our nieces, our nephews, our grandchildren. I once worked with a young case manager when I was doing community mental health. She had just given birth to her first child. She was on maternity leave, and she came into my office, and I was thrilled. Oh, you're going to show me your new baby. She's beautiful. And instead, she shut the door. She started sobbing. And she said, I can't come back to work. I know what happens in daycare. I cannot leave the most important person in my life in a daycare setting. So we can become extremely, extremely overprotective of those we love. We can project anger and blame. Again, if anybody has ever seen me work with community behavioral health, you know that I'm projecting anger and blame all the time. We do not do the best for these children. We can feel intolerance, loneliness, a lot of interpersonal conflict. We can also have a reduced tolerance of what's perceived as others' petty problems. After I had gotten out of school and I was starting to practice, about a year later I looked around and I realized I had no friends that were outside of the field I was working in. I had no friends. And so I really had to ask myself why. And the reason is because when a friend would call and say, I can't believe he didn't call me after the date, I'm thinking, get a life. This is not a big deal. Well, guess what? It was to her. It was her life. And it should have been important to me because of the friendship. But we become intolerant when we're faced with the material day in and day out of these other children. How many of you are raising adolescents? You're raising adolescents? What happens when they get a zit? It's like a major ordeal. I can't go to school, I've got a zit. And so we've got to be real careful to those we love and care for. When, again, we perceive their issues as not as important as what we work with day in and day out. We can also have disturbances in our spiritual domain. We can start to question the meaning of work and life, called cognitive schemas. So we can start to say, I got into this work because I wanted to make a difference. I knew I could make a difference. I'm not making a difference. What am I doing in this world? What am I doing in this work? If I can't make a difference in this, where should I go next? Now, it can also shatter your ability to believe the world is safe, just, controllable, or meaningful. I worry most about the spiritual symptomology because it can become pretty permanent. Sometimes there's a loss of purpose. If I'm not making a difference in children's lives, I have no purpose. There can be a lack of self-satisfaction, a hopelessness, an anger at God. A good and loving, just God would never allow this to happen to all these children. You can question prior religious beliefs. There can be skepticism about religion or loss of religion. Now, there are also physical somatic symptoms. And again, we can tie all of those into the ACE study. So we can go into shock, sweating, rapid heartbeat, breathing difficulties, aches, pains, dizziness, increased medical maladies, and an impaired immune system. We can also see interference in our work performance. We can have a really low morale about work. Oh God, here I go again. Do I have to do this again? Low motivation, avoiding tasks. Sometimes people become obsessed with the details. There can be an apathy, negativity, lack of appreciation of what you're doing and the meaningfulness of your work. A detachment, poor communication, interpersonal conflicts, and even absenteeism. We definitely see people that will leave the field and leaving your job and leaving the field. Okay, in your packet, you have something called Silent Witness. It says Silent Witness on the top, and there are three. It's just numbered 1 through 3. And what I want you to do is we just very, very quickly talked about a lot of signs and symptoms of vicarious trauma. We would like for you to list 3 of the symptoms that you have right now, or you've had in the past, and you will be sharing these with your colleagues. Once you fill out your sheet, what we will want you to do is to stand up, and it's called Silent Witness. So you're going to be quiet. You're going to hold your paper on your chest. You're going to walk around the room and read your colleagues how they've been affected by this work. I do not want conversation. The only acknowledgement is just a nod, and then move on. Does everybody understand?
Not the moment PowerPoint, all the different signs and symptoms and all those domains. Any of those are just 3.
Just 3 that you're comfortable sharing.
Because of the stuff that you're things on your body too, Margaret. It's your serious. Low morale, low motivation. Hold on, I'm not done with you yet.
This is me talking. Silent Witness.
You asked for me, Barbara. Hello. That's the first word. He said silently.
Somebody's going to have to be the first to stand up. We have a first.
What? What are you talking about? I don't know what you're talking about. You can carry mine.
What are yours, you said?
Okay, silent witness.
Can you start walking now? Can you start walking?
Can you see me going down?
getting that from? There was more words to it.
Well done, Bruce. Well done. Okay, how was it? Interesting? Observations? A lot of people with the same things. What was the number one thing you seem to see the most on people's lists? Sleep disturbance. That shows up so much. Amazing. And we're learning so much from the medical community about how important that is to our health, right? And look how much it affects people who work with our populations. What else what did it feel like? Concentration, you saw that a lot? What was the other comment?
So I have a question. So, doing this for 10 years plus, I'm not exhausted from helping the kids or working, whatever. I'm exhausted from my other duties I have, like being a mom and a wife that I have to do on top. So, it's not the work that is exhausting. I mean, it's tiring stuff, but it's everything else combined. So it was really hard to...
We're going to talk about that contributing factors.
Yeah.
So that's good. You're managing a lot, and I think that's not uncommon, especially for women. But you have to take that into consideration.
Whatever. She's also an alcoholic.
Did you hear her? So we're going to talk about contributing factors, and that's one of them. What do you bring to the game that might make you more susceptible to having those signs and symptoms?
You find this at balancing lines that age-related symptoms come from this stuff. Someone between 25 or 30, someone 60.
Yeah. Yes, definitely. That's situational too. How did it feel as a group to be doing it? Weird? Why? Why is it weird? It is weird, I know. You're exposing yourself. And didn't we talk about one of the things is you isolate? That's one of the things that aggravates it.
You also walk around silence. You couldn't explain why you answered things you answered, or like why you have one side about stuff.
Right. Although some people wouldn't want to explain. It's hard enough for them to just write those 3 words down, and that's why it's silent witness. See, everybody's different. Right. You would want to talk to a friend or colleague. You wouldn't.
Maybe I don't know if the judge me, so it's like maybe if I just want to walk, I'm thinking not doing it.
Oh. Okay. You don't want to be
We just all
judged.
ignore her. So.
Does she work?
Did everybody have 3 things? Did you see anybody with less than fewer than 3? You did? But most people put down 3? Oh. Most people put down 3. So you can say most of the people you work with have at least 3 things going on that get to them, that are happening for them because of the work you do here. How does that make you feel? It's not just you, is it? That's everybody. So if you are hesitant to talk to somebody, now you know it's a common thing. I saw a couple of interesting things going on. One is there was like an organic support group back there. Like there were people walking around and people just stood still. And everybody just, other people gravitated towards them too. So it was safety in numbers, safety, it felt safer to just stand still than to move around. That was interesting. I haven't seen that happen very much. So you guys are, that's an interesting. I saw a back rub. Somebody came and gave a colleague a back rub. That was nice. It was a good reaction to what's going on. Anything else about that? Yeah.
I think what was difficult was looking at the symptoms and trying to discern if it's a secondary cause or if it's a cause from my own trauma.
Yeah. Yep. And does it matter?
Yeah.
It's happening, right? So, but yeah, it's a good thing to think about, and that's a good segue into what we're going to talk about next, and that's the contributing factors. So we have all the things that the field that we work in, and seeing all this going on. It's hard work. It's difficult people. It's constantly coming. It never seems to end. You feel powerless sometimes, but there's other things that can contribute to already hard work being harder, making it harder for you. Situations like bearing witness to trauma. So when I worked in child welfare, actually seeing the physical effect of a child who had been severely physically abused, bearing witness to that trauma. Feeling powerless. When does that not happen? Anybody who works with, I guess, everywhere, any place. Just feeling powerless can just paralyze you. And especially when you're working in a system. You guys, I think, have learned about sort of this systems, the way systems work together. But if there's any kind of bureaucracy involved in what you're doing, and if you're working with schools, there's always bureaucracy because there's so many levels of authority and administration and government, all the way up to the federal government, dictating some of what you do. That can lead to that powerlessness. Potential of future traumatic incidents. So knowing that you work in something, tell me a traumatic incident that might happen with your kids. Here, something that you might see happen.
DCS removal.
A DCS removal from the program.
From home.
Oh, from home, okay. But the child got removed in place, okay. So you worry about that happening again with another child?
We had never been involved in it. We had to go to one of those meetings where they're placing them, but they have to talk to every party involved.
Right.
I can't remember what the name of that is, but they had room for all the kids except for the oldest girl, and right there in the meeting they said, "Sorry, we don't have anywhere to place you." And she turned and said, "Miss Barbie, can you take me?"
Oh.
And so that was like, oh my gosh, no, I cannot take you. But it was really hard to see her. Please, somebody take me. And it was so horrible to hear them tell her, nobody wants you. Out of all the family, nobody wants you. And then when she turns and says, "Well, can you take me?" That was pretty hard.
Wow. So if you go to another one of those, that could happen. It's called a team decision-making meeting, TDM.
Team decision-making, yes.
Yeah, they do that just for that purpose, but it can be traumatic.
Horrible.
Right, it can be traumatic, especially if the children are there. Sometimes they're not.
Yeah, they were there.
But when they're there and they look right at you, like, why can't you do it? Holy cow. So there's that potential of future traumatic things. If you've seen something happen before, then think about your kids who have seen fights break out at school and they're worried about that happening again. That not knowing whether something's going to happen again is toxic if you're always worried about it. And think about kids in homes with domestic violence. You never know whether this is the day it's going to happen again. And so you have to always be ready for it. You're hyper vigilant. Cumulative exposure. So this, it took me years at the court before I finally realized that so many of my court staff were reading court reports about child abuse and neglect, and they didn't need to be reading them. They needed to set the hearing, they needed to assign attorneys, they needed to make sure the mediation was set up, they needed to make phone calls. They didn't need to read all those details. There was no reason for them to do it. And I was the worst offender. I was the director, and I was reading every single report. Why would I do that? Why would I need to? And there were 30 a week, 30 new cases a week. So 120 new examples of kids being abused or neglected. I needed to read that. It was very toxic to me, and it was to my staff too, because I couldn't do anything about a lot of those. I wasn't directly involved with the families. But that cumulative exposure, now some people can't help it. Think about all the court reporters in the juvenile court courtrooms, where they're hearing 80% of the cases are about child welfare, 20% about juvenile delinquency. All day long, they're listening to people testify about abuse and neglect. All day, every day. Think about that cumulative effect on them. So that's one of the that's a situational thing that could contribute to compassion fatigue. Social and cultural context. What's happening? Is all of a sudden something happening around education that's affecting what you do? What's the political context? What's happening at the highest levels of government that's making changes to what you do here that may cut your funding or may take away your ability to teach a particular subject, things like that. Those can all contribute to that burnout. Yourself, this is where we get, what is it about yourself that can be a contributing factor? Your own personality. So what kind of score do you have on the ACE study? Do you have historical trauma? What is your personality? And we do have our own personalities, and we are affected in different ways. You cannot discount that. We all have different coping styles. Some of us go and shoot baskets. Some of us go outside and smoke. Some of us look at our phones. Some of us meditate. Everybody has different coping styles. In your packet, there's this Holmes-Ray Life Stress Inventory. How much time do we have?
I would allow them to do that and just look at it.
You've got that. It's a way for you to sort of measure the stress in your life. There's a scoring mechanism for it. Anything else you want to say about that?
No, but
it gives you the context of your own personal. So you were talking about all the other things that are happening in your life. Your kids, home, friends, those kind of things. It's not necessarily just the work that can overwhelm you, but it's all those other things. So this is the way to look at what else is going on in your life that would just exacerbate any compassion fatigue that was affecting you. What kind of training and professional history? If you have training like this, especially in the beginning of your work in the field, amazing. I didn't get it till I was in the field for 15 years. If I had learned this kind of stuff when I was a brand new CPS worker, that would have been amazing and helpful. If I had learned it when I was a supervisor, I could have been so much more helpful to my case managers. What kind of outside support do you have? Do you have any? Some people cope so well because they have so many people supporting them in their life, even if they're not working in the field. They don't have to be professional support. Your own physical condition can be a contributing factor. This whole sympathetic nervous system that Dr. Tobiasen talked about and how our brain reacts to trauma. How does your brain react? That can make a difference too. And it can affect your health. Can your body come back? Can it even itself out after you've been stressed? Or do you stay at this constant level of stress sometimes? Does it feel like that sometimes? Until Friday, at the end of the day, finally? And then it takes you till Sunday before you're feeling you have some equilibrium again and balanced? And then you start thinking about Monday? So just how do you get yourself back to that stable homeostasis that your body naturally wants to go to? There's also a self-care inventory in your packet. That's another one you probably need to do on your own. So this is the opposite of that stress index. So what do you already do that is self-care, that helps you mitigate some of these effects? And these are the things, it's a ton of them, and they're in all different, you'll see all the different domains. We have time to actually do that right now so they can use it for their...
I think it's important.
Okay, because it's gonna lead to something that we're gonna do in a little bit. So go ahead and go through that, and I want you to pay particular attention to the areas where you have a lot of strengths and areas where you need to work.
And we won't be sharing it.
Yeah. You won't be sharing it just for you, you're gonna take it home, but we're gonna use it for one of the other things that we're doing.
Okay. Grandma, everyone look at Kristen here. I was like, I know where she's going. Don't make eye contact. Don't make eye contact. No, I know what question you were talking about. I'm like, goodness, where are they going? You were...
The five. They don't have a number high enough.
With the partner?
Are you talking about the fact that you're done? Buddy. I like that word.
Don't shake my hand. No, mustard.
I don't even like mustard. Bye, Oscar. See you later. Bye,
Have a good Christmas and Happy New Year.
Merry Christmas. Happy birthday. Happy birthday.
Happy...
It's not his birthday.
She was just being sarcastic.
Because it got awkward and I don't know what to say. Do your test. 0. Heaven forbid you speak up, right? 0. I'm getting better than I have.
Which one? Self-care? Yeah. 2 more? We have 2. Yep.
What, do we keep a score somewhere?
Okay, in the interest of getting you out of here at a decent time, onto your holidays. Any thoughts about this inventory? Anything standing out to you that you didn't realize? Does anybody feel like they're really solid on all the areas of self-care? You neglect yourself. Are you noticing areas that you do really well in and others that you haven't done anything for yourself in? The point here is to try to cover every single domain. Come at it from lots of different approaches. Not just one approach to self-care. Take a look at this quote.
That's the one thing I'm getting.
We have an obligation to our students, as well as ourselves, our colleagues, and our loved ones, not to be damaged by the work we do. That comes before your obligation to do the work that you do. They rely on you to take care of yourself so that you are your best selves when you're caring for them. So that's your obligation. It's not just for your students, but for your family and your colleagues. What can you do? So you've seen, there's lots of suggestions in there in the self-caring course, so it's given you some ideas, but awareness, acknowledge that it's normal to be affected by this kind of work, and that's what silent witness really gets to, and what this whole presentation is about. Even acknowledge that it's okay to feel outraged, scared, horrified, shocked, sad, and vulnerable, not angry, those feelings that you don't like to talk about, and sometimes worry that you're feeling. It's not unusual. It's okay to acknowledge your own needs, limits, emotions, and resources. You're the only one who knows what your limits are. You are the only one who knows. You cannot expect your supervisor to be a mind reader and know that you've reached your limit. You're the only one who knows. Hopefully, you can tell your supervisor before you reach your limit. The B and A of the ABCs is balance, maintaining a balance among all of your activities, work, play, rest. You've heard that one before, and that self-care inventory really gets to that balance. Maintaining connection. I like who's the first person you're supposed to maintain a connection to? You. Again, you're the only one who knows what you're going through. You're the only one who knows what works for you, and you're the only one who knows what your limits are. So stay connected. We can easily disconnect from ourselves. I did it all the time. I'd work a 60-hour week, never noticed I was hungry, didn't notice I was tired. You just cut off your own needs. Lots of self-care. We talked about that in that. Nurturing activities, grounding activities. Playing basketball, that was a nice grounding activity. I liked that some of you did that on your break because it took you out of your head and you were doing something physical and it was kind of mindless to do. Challenge yourself sometime. Express gratitude. That's a great one. Express gratitude to your colleagues and to the people who work for you. Lots of cultural and community building activities can really help you reduce stress. Ask for help. That's a hard thing to do. And learn to say no. That's for those of you who are overloaded with lots of different things in your life. Seek lots of supervision. Anybody working with a difficult population, their supervisor is the most important person in the world. If that person can't support them or help them get through times when they're feeling compassion fatigue or recognize those things or give them permission to take care of themselves, it's going to make the job so much harder. But you can get some of that from your peers, and I saw you doing it today. Just those head nods, that was peer support and recognition that you're doing hard work. Education, do some of the research. Look at some of those links that we have at the end of the presentation. Go read some of this stuff. It might really resonate for you. In any case, it'll give you some more knowledge and tools that make you feel a little less powerless. Escape at times, that's what vacations are for. Even professional help. I know I used to send folks all the time to our employee assistance program, EAP, where they could get 10 sessions. I didn't hear about what it was about. I didn't know if they went. But we did it all the time, and it was always so helpful. Mindfulness. We'll talk a little bit about mindfulness. You guys have already done mindfulness work, right, as a group? So I don't need to explain what that is. There's so much going on in the world of mindfulness, so much reading you can do about it. I love it. And the whole point of it is really helpful to not just you who are working, but for your kids, obviously, too. It's really just being in the here and now and taking yourself out of whatever was being triggered in you. And so for kids who are having a trauma reaction, they can do a mindfulness activity. Dr. Twyson talked about the sand tray and just doing that mindfully. Just gets you out of the state of mind that you were in and away from those thoughts and emotions that you were experiencing. So you've already done some work on that, so I won't dwell on that too much. You know some of the different types, the mindful breathing, meditation's a type of mindfulness, of course. There's mindful yoga. There's team intervention mindfulness stuff. Have you done any of that? Team mindfulness? No? I haven't either. But there's team breathing, that's team mindfulness. Yeah. Okay.
Dodgeball.
Dodgeball.
That's what we do.
Hunger Games.
Hunger Games.
Let's see. Okay, you can go past this. Organizational strategies. There's lots of, we talked about using an employee assistance program. I don't know if you have that at your, you have any way to do that. Doing trauma-informed care in your organization, becoming a trauma-responsive organization. Enhancing physical safety of staff can really be powerful. At the court, it's really amazing to me that worse things don't happen in the court. Of course, we have security when people come through, and there's a metal detector and all that stuff. We have some personnel from the sheriff's department there, but mostly they're in the courtroom helping out with situations there. But amazing to me that horrible things haven't really ever happened there at the court, considering the kinds of decisions that are made in people's lives. Can you imagine a parent sitting in a courtroom finding out your rights have been severed to your child and then walk out? Depending on what their history was and their trauma history, horrible things could happen. Because once they're out the door, they're in the parking lot, horrible things could happen out there. There's no metal detectors out there. But anything that we do at the court that enhances physical safety of the staff, any kind of screenings, we see people have less stress, less of that burnout. Definitely at our CPS offices that happened. Whenever we were getting threats from anybody in particular, but they were threatening, or there was any kind of incident that happened in our parking lot, or they left a threatening message on one of my workers' voicemails. Sometimes we had no security at our offices, none. We were on our own. But once in a while, if it got to a high enough level, they'd assign an undercover police officer to sit in our lobby, and it made a huge difference. But still, it was very little. So the next activity is the letter to self. So in your packet, you also have just a blank sheet of paper, an address with a return address of the juvenile court. So given that self-care inventory that you did, write a letter to yourself about what you'd like, areas you'd like to improve in, and some very specific things you'd like to change in the next 3 months or do for yourself. It can take any form you want. No one's going to read it except you, but you are going to give it to us. Once you're done, seal it or fold it, put it in the envelope, seal the envelope, seal it, we're not opening it. Write your address on it where you want us to send it. In 3 months, it's going to come back to you from the court. Don't panic if you have a kid, a teenager, and you get a letter from juvenile court. It's from Dr. Tobias. It's a letter to you, and see where you're at. See if you did it. See if you did those 3 things. And if you hadn't, it'll remind you. And if you had, you can congratulate yourself. So take a few minutes to do that.
I think I wanted the Department of Juvenile Court tonight. Because in 3 months I'm going to forget about this and smack them today, and then we go, oh wait, never mind.
Oh, let's see, it's the word court.
What are we writing?
The letter to yourself.
That I'm writing to you, right? No chance to do this?
Hey, that's fine.
Come on.
I did. Same attitude.
I'm going to do it in emojis.
See, look at that attitude.
Except on my 8th book.
Jensen, you're being too loud. You're distracted.
And don't put the waterfall. What do you always make it like that?
Okay, bye.
Take next week off, please.
Come back next week when I remarry.
Do I write like love, Issa?
Yeah, of course you should. Yes, I like that. Very good.
Okay, and then I fold it and put it in the
irritability. Are you doing final clips? Really? You hit her surface. You didn't even hit any of us. You can't throw.
Oh my gosh.
You throw her to me.
This is how we get our anxiety out.
Wow.
I saw a startle response.
Right? That's because he was in the war and now the sound of the bomb.
Just get a flare up right now. Oh, jeez. Go back to your office.
I'm not sure him or us, I know where their office is at.
If I put parentheses on this, you just put in
Yes.
if you're doing this a higher
Do we
standard.
do we list this? Or?
This one is
This one's the list.
Just started reviewing.
but wait. You put that in mind.
Oh. Is that a list of all?
Did you already look at it? Ooh.
I can do it more than once. I haven't read the quality time. But I can look at them all day. What? I'm just saying. You asked me. So, okay. So let me see what my score is. It said it's there within the last year.
Yeah, within the last year. How do you do an address?
What's our zip code?
Record out of it.
You cannot be reading this. This is my personal letter. I'm gonna write this to you.
From the Pima County State of Arizona.
That's home.
Pima County State of Arizona.
That's right, Pima County State of Arizona.
I know he needs to write every letter they can read.
Right?
I've not written a letter in years.
So if I got a score of almost 500,
And be like, it's a love note from Pima County Department.
Do that for it.
I just said,
Is that yours?
yeah,
In the last year?
yeah.
what's yours?
Friends dying, yeah, 456.
I'm 585. I beat you.
Mine was 28. It was like having problems with your boss.
Mine's 375.
Lata, did you do your chef score?
My face is a 5, so.
Okay, you did it.
That's what I should have done. I should have had it sent to my parents' house.
Oh my god, that would have been hilarious. We're doing it.
And then we should write psych. Oh no, isn't there? That word from the border
Oh my god, I'm fucked.
Border Patrol. Border Patrol would be better.
I'm having mine sent to you.
Well, I've got kids that are like 21, so I cannot have something else.
No.
So Barbara, look at this. What does it tell you about me?
That you're not correctly like when you get out work.
You don't physically take care of yourself.
No, it's not.
Okay, neither do I. The only one that I get at.
What, how do you know if you're good? Is it work?
Oh, that was the one part of it.
Did I put it on? Oh no, I just got a name. Or touching. That's awesome.
You're so dumb.
That's mine.
Oh!
She's editing my stuff. Apparently, I'm doing better than I thought.
Stop it.
Not me personally, but I do it.
I was like, is FaceTime the night? Good?
Oh my gosh, Kenji, let me
That can help me with that? No. I'd rather be a monk in a mountaintop.
Or which one I'm best at. Face the cancer stuff.
Why? They're gonna be like, that was the best soap opera video we've ever had. Those two little kids.
Or great.
You still have one?
You know what? Regarding the monarchies, I think that's all good. She put that down.
It's because Mrs. Emerson wrote like 2 sentences. Okay, your handwriting full page is like 5 sentences.
Ask him if he's like really good, if he can practice when he's been gone and just like that.
But you can multitask.
What do you do?
As I said, I shut up. I can ask him
I can do like put it in a picture. I can get like a lock of my hair. You can put it in a bowl with some stones and some chicken bones. You can. If you like,
There'd be more. Yours was
We're still waiting for a few people to finish their letters. We do want to leave you with a wonderful saying of one of the religious world leaders, the Buddha. If your compassion does not include yourself, it is incomplete. We want to really thank you for spending the afternoon with us. I apologize for going over. We knew...
Jansen does it all the time, so we're used to it.
Oh, they do it all the
it's
time?
great to have an interesting training.
Okay, thank you. Does anybody have any questions? Then thank you. If anybody has any personal questions, our contact information is on both of the PowerPoints on the last page. We would look forward to hearing from you. And again, thank you, and have a wonderful holiday season.